these. So let me start off with the first case. So we have a 10 days old neonate who was brought to hospital with complaints of crisis. So I'll be taking you through this adrenal crisis topic by the use of 4 scenarios, and then at the end we'll have some discussion. So case 1 is we have a 10 days old neonate who was brought to the hospital with complaints of not accepting feeds well. He was vomiting and decreased activity. So we know with this lethargy, this poor intake of feeds and vomiting, which are classical signs of either it's shock or else it's adrenal insufficiency or infection or hypoglycemia. These can be the various manifestations of as these symptoms. But on examination, the peripheries were cold. They were lethargic. The baby was lethargic. The oral cavity was dry, so you can see that there was dehydration, and the skin turgor was prolonged. And the baby also had ambiguous genitalia on examination. And the test showed hyponatremia, hyperkalemia, and metabolic acidosis. So with these things, if we remove the ambiguous genitalia part, there are a lot of DDs, but when it comes to ambiguous genitalia, then the first thing we consider is the CAH. And more than 90% of cases of CAH are due to the 21 hydroxylase deficiency. And that is due to the gene. So that is the 21 hydroxylase gene. When there's either deletions or mutations, then we have this 21 hydroxylase deficiency. And then there's defective conversion of 17 hydroxyprogesterone to cortisol in this 21 hydroxylase deficiency. There's also a defect in the aldosterone production. Let me take you to the pathway now. So in 21 hydroxylase deficiency, as you can see here, this step is defective and it's not working properly. So the enzyme is missing or deficient. And as you can see here, the aldosterone, which is the end product here, and the cortisol, which is the end product here, are not synthesized well. In the salt wasting form, that is a classical form, the salt wasting form, you have deficiency of cortisol, aldosterone, and you have very low levels. That's why it manifests as salt wasting and cortisol deficiency manifesting as hypoglycemia and poor weight gain. Now, the other types of, in classical CH, you also have the simple virilizing type of CH, which also comes under classical. And the salt wasting form usually presents with genital ambiguity, as well as simple virilizing form can present with just mild clitoromegaly or also some amount of posterior labial fusion. Whereas the salt wasting form, usually due to the increased androgen levels, manifests with a more severe form of genital ambiguity, and also the degree of ambiguity is more in such cases. So they present with failure to thrive and all the symptoms that we have seen, signs and symptoms we have seen in the case above. Whereas the non-classical CH is a late onset CH, this is wrong. And then it can present with premature puberty, a slightly accelerated bone age, and a hirsutism, infertility, acne, or irregular periods later on in adolescence. So these are all the symptoms of classical and non-classical CH features. Now the treatment is directed towards providing the glucocorticoid and mineralocorticoid in sufficient doses to reduce the associated excess CRH and ACT secretion, and also to control the hyperandrogenemia. In case of hydrocortisone for glucocorticoid replacement, the usual dose for maintenance is 15 to 20 mg meter square per day, divided in 3 doses. Whereas in case of when we start off treatment, we usually start at a higher dose and then gradually taper it down to this dose. And rarely also we can see somewhere between 10 to 20 mg per meter square per day also. The requirements might be a little bit less also in a few cases. Whereas fludrocortisone is for mineralocorticoid replacement, and the dose is 0.1 to 0.3 mg once or twice daily. The maximum dose usually we go up to 0.3 mg per day. This seems to be wrong. And we usually give either 0.1 or 0.2 mg per day, and rarely 0.3 mg per day is required. Salt intake, again, the recommended intake is 1 to 5 grams salt per day, but usually we start off a little bit less, so 1 to 2 grams salt, or 4 milliequivalents per kg per day, or 17 to 54 milliequivalents per day is what is recommended. Now, the other cause of CH, like there are many enzymes which are there in this pathway. So we have the 11 beta hydroxylase enzyme, we have the 3 beta HSD enzyme, then we have a 17 alpha hydroxylase enzyme, and there's also the proximal and the proximal steps here where the cholesterol gets converted into pregnenolone, the star enzyme, and the cytochrome P450 side chain cleavage enzyme deficiency as well. So anywhere along this pathway, the enzyme may be deficient, and we might get different manifestations. And here you can see the aldosterone synthase enzyme. Sometimes this enzyme alone gets affected, and you can have just isolated aldosterone synthase deficiency causing hypoaldosteronism. So that again can present with poor weight gain and hyponatremia, hyperkalemia. So these can be there, but without the cortisol deficiency signs. So we can, the other things like lipoid adrenal hyperplasia, deficiency of P450 oxidorreductase, and then the 11 beta and the 3 beta hydroxylase deficiency, hydroxysteroid dehydrogenase deficiency. Now coming to case 2, this is an older boy. So he's 2 years old, presented with fast breathing and lethargy. So he has history of URI, and he was developing normal child. And along with URI, he's developed this lethargy and fast breathing that you can see. And on examination, child had hyperpigmentation. There was low blood pressure, and the blood gas showed metabolic acidosis. So this is an older child, not like a neonate, and he's developed intercurrent illness. And you can see that there are other signs of adrenal problems based on hypotension, hyperpigmentation, acidosis, and the fast breathing being acidotic breathing. Now, the etiology for such cases, again, present a little later, are inborn defects of steroidogenesis or adrenal hyperplasia congenita, which can present a bit later, and adrenal leukodystrophy if there are other features of CNS involvement as well, familial glucocorticoid deficiency, disorders of cholesterol synthesis and metabolism, and Addison's disease. Whereas if you look at infections, then tuberculosis, meningococcus can efficiency, and drugs like ketoconazole, etomidate, and drugs such as rifampicin, phenobarbital, phenytoin reduce the effectiveness and bioavailability of corticosteroid replacement therapy. So again, one thing we should keep in mind when somebody is on anticonvulsants as well as the steroid medications. Then rarely there's trauma and hemorrhage into the adrenal glands, which can present with adrenal insufficiency. Now, again, the manifestations here, this older age group are fatigue, anorexia, weight loss, nausea, vomiting. They can be generalized myalgia, so joint pains, non-specific symptoms. And along with that, there can be low blood pressure as well as hyperpigmentation in the mucosa or the skin in particular areas. And lab findings, again, in such case, will be usually hyponatremia, hyperkalemia, hypoglycemia, ketosis, acidosis, low cortisol levels, there's some amount of lymphocytosis, high ACTH level, and high plasma renin activity due to low aldosterone levels. Here again, the immediate treatment would be vigorous resuscitation. So initial fluid resuscitation, which you all know, and then also giving glucose containing fluid, and then correcting hyperkalemia by all the measures that we have, the sodium bicarbonate, the calcium gluconate, and the other measures, and insulin if required. The insulin not immediately when required, but after correcting the hypoglycemia, then if you give the steroids, and if required after that, you should give insulin. And then hydrocortisone can be given IV bolus initially and divided again in 4 divided doses over the first 24 hours, and then gradually tapered. Now, hypothyroidism also should be looked into. And if at all hypothyroidism is there coexisting, then that should be treated. The cortisol deficiency should be treated first, and then only thyroid replacement should be started. Otherwise, it can precipitate adrenal insufficiency when we start thyroxine initially. Because, then there's autoimmune disorders, the thyroid can also be affected, and it can manifest coexistingly as well. Now, after acute manifestations are under control, these patients require chronic replacement therapy for cortisol aldosterone. Usually the doses required here are slightly lesser, around 10 mg per meter square per day in 3 divided doses. And a bigger child, then you can give prednisolone and equivalent doses in 2 divided doses as well. Now, coming to the third case here, it's a 1-year-old child who was brought with complaints of fever, cough, cold for 3 days, lethargy, and poor feeding with fast breathing. there's a infection, and then there's lethargy, poor feeding, fast breathing, and child on examination had tachycardia, hypotension, vomiting, prolonged CFT. This child was managed with septic shock, as you all will be very much aware of. The first thing to be looked into is a septic shock. But however, despite giving the fluid boluses and inotropes, vasopressors, the blood pressure was low, and then the features of shock persisted. So this is a common scenario in ICUs, which you definitely see. And this is septic shock, not secondary to adrenal insufficiency, but instead it's adrenal insufficiency secondary to septic shock. And here again, you would require a hydrocortisone, either a bolus dose or infusion, giving a stress dose of 50 to 100 mg per meter square per day. And then that is the dose required to reverse the shock. And absolute adrenal insufficiency and septic shock can cause death, very soon in such cases. And it's also important to measure serum cortisol level before the administration of hydrocortisone if possible. Now, this is a very common scenario, and septic shock should be managed along with hydrocortisone if required, if it's refractory. Now, case 4 is a 4-year-old child who is a known case of SRNS, steroid-resistant nephrotic syndrome, who presented with severe abdominal pain. Now, on examination and other investigation, this child was diagnosed to have bacterial peritonitis, as we know is common in nephrotic syndromes. So the question here is, what stress dose of hydrocortisone is given in this child? And do we need a stress dose? And when should we give the stress dose is the question here. So importantly, it's important to remember that stress dosing is when there's features of shock, when there's features of circulatory insufficiency, if there's hypotension, tachycardia. These are scenarios which needs to be given. Where if it's just fever and just mild infections, then the dose has to be doubled. Where if it's high-grade fever and this child is crossing more than 102, 103, and the child looks very sick, then it's ideal to give 3 times the dose of glucocorticoids, the hydrocortisone. Whereas the stress dose is required if there are features of adrenal insufficiency in terms of circulatory failure or shock, and tachycardia along with that. So stress dose of hydrocortisone in minor illnesses is 50 mg per meter square per day, and in major illnesses is 100 mg per meter square per day. Usually we give up to 100 mg stat dose, but it can be increased to 150 and 200 as well, depending on the weight and the condition of the child. So in these 4 scenarios, I have showed you how different presentation of adrenal crisis comes from a neonate, in an infant, and in case of infections with septic shock. And then lastly, when there's child is under treatment for steroids with something else, and then child develops infections, and what should be done. So with this, I've come to the end of the talk, and there's any questions, then we can discuss on them.
It was a very crisp and a very clinical presentation, and I believe that the topic itself is very much in depth and a very small topic, but very important, because if once missed, it causes a lot of chaos in all the ICUs. There are no questions as of now till now, but in case there will be any, we will be sharing. I have one doubt in my mind, that when these patients, they go home, what are the usual problems with which these patients come back in OPD? Is it always in emergency that they come back, or does these regular drugs have their own some side effects associated with them, which we should be able to manage?
Yeah. So usually, as we know, these are chronic illnesses, and they usually come for once in 3 monthly follow-up when we ask them to come. If initially, probably we call them once in 1 month or 2 months, but later on once in 3 months. And every time they do the tests, and then they come and we adjust the doses. But every time they come to the visit, like you say, we should look for the blood pressure. Which is very important to look for signs of sterotoxicity, and also the aldosterone excess that we're giving fludrocortisone. It's also important to check the growth of the child. Are we giving too much of steroids? Is there stunting? Is the child growing well along the lines? And it's also important to see for features of Cushing's syndrome, giving too much of steroids, and then you find features of child's face being Cushingoid. So these are some of the things that we look into, because the lab tests as such have to be taken into correlation along with the clinical examination findings. So in addition to doing 17-OHP, the renins, we should always correlate it to clinical growth, clinical BP monitoring, and also the body surface area. So these are some of the things that we look into. Usually, there's no signs of toxicity if well managed, unless follow-up is missed and they keep continuing the same doses. So acute crisis, like you say, Dr. Nathan, is when they have fever and then surgeries. Then those are the times when it's a bit more challenging. And most of the times they do well, but sometimes severe infections can cause them to go into admissions, and then a slow taper after increasing the dose will help in such cases.
My second question is, when we see these patients in ICU for first time diagnosis, uh, if the dyselectricity, or let's say, how frequently do we see systemic or involvement like cardiac compromise state or associated effect on the kidney along with the child with adrenal crisis? Is there a correlation between cardiac compromise state and adrenal crisis?
A lot of times the adrenal insufficiency at the time of at the time of presentation to the hospital, when they come to the ICUs to do late diagnosis, then most of the times they are in pre-renal ARF. That's what I've seen. And then, as with the regular treatment of the adrenal insufficiency with the steroids, the hydration, it usually improves quite rapidly over 24 to 48 hours. Regarding the cardiovascular effect, well, I think it's quite well compensated, and as such, I don't think there's any
Direct
cardiac
correlation.
failure coming, cardiac failure in these such cases. It's rather mostly a circulatory compromise which happens, I guess. Yeah.
Okay. We have two questions. One is by Dr. Chandramouli. He asks whether Addison disease has any effect on pregnancy and fetus.
If somebody has Addison's disease, then whether it affects the fetus and pregnancy. Well, normally if they go into pregnancy, then I'm not sure, because I'm a pediatric endocrinologist, but normally they would be able to manage the pregnancy with proper monitoring and proper adjustment of the doses, and it would not have any effect on the fetus unless it's something which is inherited, and then we would have to check by amniocentesis to see if the fetus affect or not. Yeah. If it's
I think
autoimmune,
he wants to ask about the effect of medications as well on the growing fetus, whether these drugs affect growing fetus as well or not.
okay. So normally we don't see, I don't normally see at adults and pregnant women, but then if given proper doses and properly adjusted, I wouldn't think there's a reason to have any compromise on the fetus as such when given for this condition. If you're talking about CAH in particular or adrenal insufficiency in general, well,
The
if it's,
question says Addison disease in pregnancy and its effect on fetus.
yeah, so
So
Addison's, I think it doesn't have much effect.
okay.
But if you're talking about CAH, then it's a different scenario again, because right now it's only in trials that prenatal treatment of mothers with steroids is being undertaken. It's not routine care, because 1 out of 8 child only is the likelihood of having a virilized female if you have a sibling, if the mother has another child with CAH. So because of the lower 1 in 8 chance, you're treating 7 out of 8 kids unnecessarily, which can lead to other toxicity problems of giving steroids. So that's where in CAH it's different. It's still under trials that prenatal treatment of dexamethasone is there in CAH.
Our second question is by Dr. Vikas. He mentions he asks about the duration. About after what duration of prednisolone or steroid supplementation HPA suppression occurs, and we should consider tapering the dose before stopping it.
So normally the question is after what duration of steroid supplementation. So normally the general rule is that if it's more than 2 weeks that the steroids have been administered, or if high doses have been administered, then the HPA suppression is likely to happen. And in such cases, we need to give a slower taper. And taper again, we should consider, depending on how long it was given, we should consider the rate of tapering. If it's only for short duration, like 2 weeks, Suppose there's a child with asthma and was given during the acute exacerbation, you should try to taper it fast and finish it within 2 weeks. If it's prolonged, then because only a short duration, you can still taper up faster and monitor the child. But if it's for something like a nephrotic syndrome, which required longer duration of treatment, like 6 months, 1 year, then you should do a slow taper. And normally, what is the best recommended is when somebody is on steroids for a long time, when they're going back to a equivalent dose of hydrocortisone 10 mg per meter square per day of prednisolone, if they're already on prednisolone or methylprednisolone, it's good to convert them into hydrocortisone 3 times daily. Give around 5 to 10 mg per meter square per day, and then again you taper that every weekly or every 2 weekly. And then at the end of it, when you go down to 5 mg per meter square per day, you skip the evening dose and then check a morning cortisol. If the morning cortisol shows a good recovery and if the level is good, that means the HP axis recovery has happened, and then you can safely stop the medication. However, if the levels are still intermediate and then not very well raised, then again you should consider continuing the high zone for a slightly longer period, a few more months, and then reassess the HPA axis. And the best way to examine the HPA axis recovery is again the low dose synaptic stimulation test. It will tell us if it's recovered for sure or not.
So if a person is on, let's say a child with respiratory distress is there, and we started the child on IV hydrocort or IV methylprednisolone, and we give it for 3 days. So when we stop this after 3 days, do we need to taper these steroids, or we can directly stop it?
Yeah, when it's for an acute indication and you've given it for 3 days or 5 days, then you can acutely stop it. But if you're tapering it and giving it for more than 2 weeks, then it's better to do a slow taper and then come down. Yeah.
Like in COVID MISC, we have given pulse 30 mg per kg for methylpred. Now for after 3 days of pulse, do we should taper and stop? Because
If the primary indication for the disease is to continue it for a few more duration, then we should. Otherwise, I don't see any HP axis suppression due to giving it for 3 days and as such. But
okay.
Yeah, if it's a very high dose, like 30 mg per kg pulse dosing, then I'm quite sure that it's continued for a slightly longer period after that and then gradually tapered. But if it's still given for only 1 or 2 days and then stopped, I don't see any reason for HP axis suppression.
How do we convert if somebody is choosing methylprednisolone and now they want to shift to hydrocort or dexamethasone? How do we convert the medication?
So there are there's a table called leading to the conversion factors, but I think there are very nice apps also now by which we can use and then convert it. So I normally tend to use the apps, but there's a very nice table which I did not show here, which we can use to convert using a conversion factor. Yeah, but it's different for different drugs. It's difficult to remember, so it's always good to refer that and then convert it as such.
Can you please share it with me? I will share it with all the participants. I think it will be very useful for all of us to have that table as well as that app with us, so that this conversion and associated benefits of that conversion, why we are choosing it, can be transferred to the patient itself.
Yeah, sure, sir. I will.
That will
I
be
think
great.
that makes a lot of our it makes our decisions more accurate, and then we
Yes,
can
simpler and easier.
that's right.
Definitely. I think there are no more questions, and we'll close